Hi friends, this is one of the finest cases that you will get. In fact, it is something that has been often tested even in the USMLE or the MRCP examinations. This 23-year-old male is having a Marfanoid habitus. And how do I so confidently say that? Because he's disproportionately tall. His arm span is more than the height. Along with it, you might find some other features like a high arched palate. You can find something called arachnodactyly. A very specific cue that has been given in this question is that he requires thick glasses. And often this is due to a phenomenon called ectopia lentis, where the lens moves out of its normal position in the eye and dislocates to a superotemporal location. Remember, in Marfan syndrome, we have a superotemporal dislocation. How do you remember it? Fan is located above and on the temporal side. In any room, the fan is always located above, that's superior, and on the temporal side. So that means we can easily remember that in case of Marfan syndrome or Marfanoid habitus, we can find a superotemporal dislocation of the lens. Along with it, he was previously told by a physician that he might be having a murmur. And indeed, in cases of Marfan syndrome, we can either have two presentations in the cardiovascular system. One can be the aortic root dilatation that can happen, or as very specifically said in this case, we might have something called a mitral valve prolapse. So that is what is actually giving rise to the murmur. Now, how has this patient presented to us in the emergency? He's come with a left-sided sharp pleuritic pain, shortness of breath, and he's denying fever. He's denying any infectious etiology. He's denying any of these because we are not looking at a pneumonia here. What we are typically looking at, and that is exactly what the chest x-ray is also suggesting, is a left-sided pneumothorax. Most of these patients of Marfan syndrome have a very high tendency of developing a spontaneous pneumothorax. So the correct option or the correct answer to this question is actually the rupture of a apical subpleural bleb. That would give rise to the pneumothorax-like presentation. How do I clinically elicit a pneumothorax? I'll find a hyper-resonant note on the left side. Along with it, there'll be an absent breath sounds. I repeat, an absent breath sounds on the affected side, that's the left side here, and a hyper-resonant note on percussion. On chest X-ray, I can clearly find that there is a contralateral deviation of the mediastinum, which means that since it's a left-sided pneumothorax, the mediastinum has shifted to the right. There's a rightward tracheal shift that can be seen in the chest X-ray. This, along with the clinical features, is actually a case of left-sided spontaneous pneumothorax. Just an additional point that might help you later for your future knowledge and exam purposes. Marfan syndrome is an autosomal dominant disorder that is caused due to the mutation in the fibrillin protein. In the fibrillin gene, FBN1 gene, which is located on chromosome 15. Thank you for a patient hearing. Lots of love.